So here's a diagram of the duodenal switch. My partner, Dr. Baker, already discussed the sleeve gastrectomy where we remove part of the stomach and we leave this tube that we call a sleeve, and I'll refer you back to his section if you want to learn more about that. But the duodenal switch does have a sleeve, but then what we do is we divide part of the intestine called the duodenum. So you can imagine that this part used to be connected to that part, and that's called the duodenum, but we're going to switch it up. So we have to divide the duodenum, and then I come way downstream and I find the beginning of the colon, and I'll measure the intestine back, and this is what's called the common channel. And we can vary the length of the common channel with the duodenal switch based on how much malabsorption or absorption of nutrients that people are able to take in. But then we divide the intestine, and we'll bring that piece of intestine up and make a little connection here, and we have to make another connection downstream. So by doing this, food goes down this channel, but juices from the liver called bile, which we need for fat absorption, and juices from the pancreas that's not drawn on here, the pancreatic juices help us absorb protein. They're going to empty into this channel, but food's not going to be along that channel, and it's not until we get way down here that the food from above mixes with the juices, and then over the length of the common channel, we're going to absorb nutrients. So with this operation, people aren't eating as much and they're not absorbing as many calories, so they have better weight loss with this. As a matter of fact, they actually have better remission of cholesterol issues and high blood pressure as well as diabetes. And so that's all really, really good. Unfortunately, it comes at a price, and the price is we're bypassing where iron and calcium are absorbed. So we actually have to supplement iron and calcium, but that's not the only nutrients. We also are impeding the ability to absorb vitamins A, D, E, K, zinc, copper, a lot of different vitamins. And so what we have to do is put people on supplements, and we have to use a lot of supplements. So it probably costs about $100 to $150 a month just in vitamin supplements for patients after they have a duodenal switch. And sometimes they actually have to take those supplements up to 5 times a day, and even with that, they might not absorb it appropriately. So on occasions, we'll have to do things like iron infusions. Sometimes people actually have to buy vitamins that are in a patch form, and they wear it as a patch. So there's a lot of different things that we have to do to make sure that their nutrients are where they need to be. And they also have to have more common or more frequent blood draws and lab checks to make sure that we're keeping up on all their nutrients. The other thing to know about the duodenal switch is people don't absorb sugar as well. And if they eat too much sugar, then ultimately what they will get is really, really bad smelling gas, and they will also get diarrhea. And so these patients also have to follow a lower carbohydrate diet. So that's the duodenal switch. And we're also going to talk about the SADI. Now, I don't have a diagram of the SADI, which is a single anastomosis duodenal ileostomy, but what we do with the SADI is we actually don't divide the intestine downstream. So what we do is we just bring a loop up, and we connect that loop up to the duodenum. Now, the benefit of the SADI is that it's an easier operation. And that easier operation means it's a faster operation, but there's a downside with it. And the downside is because we're not dividing the intestine, the juices from the liver and pancreas are actually going to be in contact with food for a longer distance. And remember I talked about we can vary the length of the common channel with the duodenal switch. With the SADI, we tend to keep that at a standard length, which is roughly about 9 feet in length, or 300 centimeters. We usually will measure it in centimeters. And so that's really a big difference. The SADI is a newer operation. We don't have as much data on it, so it's less frequently performed than is the standard duodenal switch. On this segment, we're actually going to talk about revision surgery. And sometimes we do procedures that don't have the outcome that we're looking for, and we sometimes will have to revise an operation to a different operation. Examples of this would be the laparoscopic adjustable gastric band, what a number of people know as the lap band. And with the lap band, sometimes people will either not have effective weight loss, or they might have some reflux or difficulty swallowing. And what we have to do is convert that band over to another operation. So some of those operations would be converting it to a vertical sleeve gastrectomy, gastrectomy, to a Roux-en-Y gastric bypass, or to a duodenal switch. And you can go back and look at all those sections on each of those procedures to know a little bit more about it. The other thing is sometimes with the vertical sleeve gastrectomy, people will have significant reflux after that, and we might have to actually revise a sleeve over to a Roux-en-Y gastric bypass, and that's a better anti-reflux operation. The thing to know about revision surgery is it's harder, and the reason why they're harder procedures is because somebody's already previously had surgery, so there's going to be scarring related to that. There's some literature to suggest that anytime we do revision surgery, it carries a higher rate of a complication, and some of the literature says that that rate is 4 to 10 times higher than the original procedure. Fortunately, within our group, we're not seeing rates that high, but it is important to know that it is a more complex operation, and therefore it does probably carry a slightly higher risk associated with it. And the revision surgery is a very tough topic. I can't cover everything just in this short video, but if you're someone who's interested in revision surgery, we'd want to meet one-on-one so we can go over the particulars in regards to your history and what we have to offer with that.